Very good evening to one and all. On behalf of Celestial Division of Intas Pharmaceuticals, myself, Dr. Nilansh, I would like to welcome you all, allied neuroclinicians, for tonight's scientific fest, which is EMAP Forum. It is a knowledge-sharing webinar platform, basically. As we all know that multiple sclerosis, even though after so many research and years, it still remains a conundrum. Whether it's therapy, whether it's pathogenesis, whether it's types of multiple sclerosis, everything is still mystery hanging around. So that we thought that we should develop some platform where all some relevant clinicians and neurons come together, have scientific discussions, and have a way to deal with the problem or address the problem in a better way. The reason we have conceptualized this platform EMAP Forum. Tonight, for the same purpose, we do have Dr. Vollmer from USA, Colorado, with us as a thought leader, who will share his clinical experience and research experience with us on the same topic, multiple sclerosis and role of monoclonal antibodies in them. Now, about Dr. Vollmer, it is difficult for me to embody clinical research experience here. But if I have to say something, Dr. Vollmer is a professor of neurology at University of Colorado. He is a medical director of Rocky Mountain MS Multiple Sclerosis Center and also a co-director of the Rocky Mountain Center for Multiple Sclerosis Care and Research. He is a fellow of American Academy of Neurology. He is also a proud member of several professional societies like American Association of Immunology, Society of Neuroscience, Consortium of MS Center, and many more. Dr. Vollmer is a proud alumni of Stanford University and Yale University. He has more than 100 publications in the peer-reviewed journals around. He has a special interest in the multiple sclerosis and immunotherapies of the multiple sclerosis. Dr. Vollmer has been awarded so many times. He has been solicited for top doctors by Kessel Connolly in 2015. He has been named in the best doctors of America in 2013. He has also been honored with the Physician of Distinction Award under the Accelerated Cure Project for Multiple Sclerosis and National Multiple Sclerosis Society Volunteer Hall of Fame. Now with that, I would like to welcome Dr. Vollmer here on behalf of the Intas Pharmaceuticals and the whole neurology fraternity sitting here or gathered here. Now coming between you and Dr. Vollmer, I would like to request Dr. Vollmer to take the reign of this session in his capable hands and enlighten all of us further. Please, Dr. Vollmer. Yeah.
Thank you very much for that kind introduction. It's an honor to be able to talk with you all tonight. And I'm going to be focusing tonight on the role of B lymphocytes in MS, but I'd like to start out the conversation about the value of early treatment of MS with highly effective therapies in order to maximize lifelong outcomes for our patients and minimize their risk of disability. So these are my disclosures. Note that I have been hired as a consultant by both Genentech and Hoffman LaRoche, which make some of the monoclonal antibodies I'm going to be talking about tonight. So just to briefly review, MS is a leading cause of irreversible neurological disability in young women in the United States, and the second leading cause of irreversible neurological disability in young men. In the United States, we estimate that there's more than 400,000 MS patients, but we think that that is an underestimate and that the number is probably closer to 800,000. And it's been estimated that worldwide there may be 3.2 million people with this disease. In the United States, MS is the second most expensive chronic disease behind congestive heart failure. Now, we have a lot of evidence that disease-modifying therapies do actually slow the progression of disability and decrease the rate of conversion from relapsing MS into secondary progressive MS. But however, as you know, without treatment, about half of patients will end up in secondary progressive MS within 10 years of disease onset. And also by 15 years of disease onset, half of patients will be using a cane or more for ambulation. So this is a serious disease that does result in disability in 70 to 90% of patients that are affected. Now, there are different forms of MS clinically. As you know, there's the relapse-remitting form. 85% of patients will present with this form, and if they're not treated, 70 to 90% of them will ultimately enter the secondary progressive phase of the disease. About 15% of patients present with onset of slow progressive loss of disability. And in 1/3 of these patients, they will ultimately have a relapse. And these are represented here, these figures, from Dr. McAlpine's books a number of years ago. I'd like to make one very important point when you read about or hear about treatment of relapsing remitting MS versus secondary or primary progressive MS. And that is the patients who have onset of progressive disease either at the beginning or after having relapses are on average about 15 years older than the patients who have onset with relapses. So whenever we look at studies that are reporting results of treatment trials, it's very important to keep in mind that this age difference is actually extremely important to understanding the outcome. And I'm going to go over why that is over the next few slides. In order to understand why this is such an important issue, I'd like to introduce the concept of neurological reserve and neurological resilience. Now, I'm using these terms a little bit differently than they're used in the literature, and I'm applying them specifically to MS, and I'll show you some reasons why in a second. But by neurological reserve, I mean the capacity of the brain to compensate for subclinical damage without clinical evidence of dysfunction and without loss of neurological function. The neurological reserve, as we all know, is quite evident in particularly young people. And it's also very important for helping people to age normally and not have a loss of neurological function until late life. Neurological resilience, I'm going to use this term to refer to the capacity of the brain to recover function after neurological injury. This is not just relevant to MS. In the United States, it's been a big issue in contact sports such as American football, where players are having closed head injury that's using up their neurological reserve and they have onset of progressive disability in their 40s and 50s. The same thing happens in MS. So this is an example of the evidence that there is brain and cognitive reserve in MS. This is a paper from James Sanowski and the group. In the top figure here, they're looking at cognitive function as a function of intracranial volume. And what you can see is patients that have larger brains tend to perform better on these cognitive tests. Down here, what they're showing is that patients that have larger brains, which are up here, compensate for increasing MS lesion load better than patients who have smaller brain. So brain size is important in terms of maintaining neurological function and compensating for increasing T2 lesion load. Over here, what they're demonstrating is that there's also an active component to the neurological reserve. In other words, patients can increase the reserve capacity of their brains by living an active, healthy lifestyle, which includes physical activity as well as good nutrition and social interaction. And so patients who have an active lifestyle, which they're referring to as increasing cognitive leisure, actually also perform better on the cognitive tests, and they also can compensate for increasing MST2 lesion load better than patients who are less active. So this actually has fundamental implications for the treatment of MS. It implies that we really do want to try to maintain brain volume, and we want to get patients to live active, healthy lifestyles so they can compensate better for the burden that MS causes for these patients. This is more evidence of this. This is a very recent paper, just came out a few days ago. It's from the same group, Dr. Sanowski's group. And here they followed patients for 5 years, and they stratified them based on brain volume. And what you can see is patients who had larger brains over those 5 years had less increase in disability as measured by the EDSS, which is primarily an ambulation scale, than patients who had smaller brains. So again, brain size is important, and I'm going to talk a lot about that over the next few minutes. So I would argue that the primary goal in the treatment of MS with disease-modifying therapies of any sort is to really maximize lifelong brain health by preserving neurological reserve or brain volume in early MS in order to buffer for the effect of MS and also to buffer for the effect of just normal aging on the brain. To accomplish this, we need to diagnose MS as early as we can. We need to help these patients adopt a healthy, active lifestyle and to avoid comorbidities such as hypertension or diabetes that also tax neurological reserve and increases the risk of disability. And we also need to use the most effective disease-modifying therapy we can in a patient that has an acceptable safety profile for that individual as early in the disease course as we can. So why is treating early and effective in MS critical to preserving neurological reserve? Well, the first reason is that the frequency of relapses and new MRI lesion formation is actually greatest at onset and in young age and declines with age. This is an example. This is looking at relapse rates, and what you can see here is the relapse rates are maximal in 20 to 30 years of age. They steadily fall off. By the time patients reach the age of 60 or so, their MS disease activity has dropped by 70%. This is also true for new MRI lesion formation. You just multiply these numbers by 10, and you see exactly the same curve. And in fact, the inflection point in terms of decreasing disease activity on MRIs is actually at age 35, at least in European and North American studies. This is further supported by a recent pathology paper from Claudia Lucanetti and the group, and they were looking at MS brains from patients at various ages and various lengths of disease duration. And in the pink and blue up here, this represents inactive plaques and shadow plaques. So these plaques are old plaques that are no longer inflammatory. In the green and the light green here, these are late active and early active plaques. And what you can see is at onset, almost all the plaques are early active and late active. They're actively inflamed. But as patients have longer disease duration, the majority of their plaques are actually old plaques that are burnt out and no longer immunologically active. And this is important because if our anti-inflammatory therapies only really affect what's going on in these early plaques here, they do not affect what's happening in these plaques out here. So if we want to maximize therapeutic efficacy, we need to treat early in the disease course when most of the patients are still active. Second reason is that most newly active MRI lesions, in fact, over 90% on a 1.5 Tesla MRI machine, are clinically silent. They're not associated with relapse, but they are resulting in brain volume loss. This is just to point out that brain volume loss actually occurs at all phases of disease. It's already present at patients that had their first clinically isolated syndrome, their first attack. And despite common wisdom, the rate of brain volume loss does actually not increase with disease duration. In fact, if you adjust for age, it actually appears to decrease a bit. In other words, the rate of brain volume loss is actually greatest at onset where there's the most inflammation. And this is just one of many studies that have demonstrated this repeatedly, that most MS lesions are clinically silent. So the dark green bars here are the relapses that occurred in these 7 patients that were getting monthly MRIs over the course of a year. But if you add up the number of actual new lesions, there's over 50 new lesions that occurred in these patients in the same time frame. And this has been confirmed in study after study. Now, the fact that these inflammatory lesions are important is further demonstrated in this later paper. This is a study where they did monthly MRIs for 6 months, and then they followed the patients for an additional 12 months, or a total of 18 months, and they looked at the rate of brain volume loss at month 18. And what you can see here is there's a very strong correlation with number of active lesions and the rate of brain volume loss. And in fact, in terms of all the variables that predict the amount of brain volume loss over this 18 months, 80% of it was explained just by the number of new active lesions. So active gadolinium-enhancing lesions, as they occur, the number of them is extremely important to the rate of brain volume loss. Next point is the rate of brain atrophy is actually a strong predictor of future disability in MS. So this was a study done a number of years ago by Beth Fisher at the Cleveland Clinic. These were patients that were being followed in the Abinix trial, and they had brain volumetrics done over the first 2 years of the study. In this analysis, they had followed the patients for an additional 6 years, so a total of 8 years of follow-up. And they stratified them into 4 groups, those with the least rate of brain volume loss in the first 2 years, and those with the greatest brain volume loss in the first 2 years. What you can see is that the patients that had the greatest rate of brain volume loss in the first 2 years were 4 times more likely to reach an EDSS of 6 or greater, which means they had to use a cane for ambulation. So brain volume change is incredibly important. And it was confirmed by Maria Pierce-Tormani in a recent paper where she analyzed the placebo data from a large number of our phase 3 clinical trials for essentially all the drugs that we currently have approved. And what she demonstrated that over 2 years of outcome, the rate of brain atrophy explains about 50% of the variance in terms of disability over the 2 years. The number of new lesions that occurred during that time explained about 50 to 60% of the variance in the outcomes. But if she combined these two, she explained about 70 to 80% of the variance in terms of disability just over 2 years. And she also demonstrated that the longer you follow the patients, the more important the rate of brain volume is in determining disability. And finally, brain reserve is compensating for this clinically silent disease in the relapsing form of MS through cortical remodeling and other mechanisms. And I would argue that it's the loss of this neurologic reserve that explains the onset of progressive MS. So this is a functional MRI study from Massimo Filippi's group. These images are composites of multiple subjects, but basically they're having patients do a simple tapping test in the MRI. What you can see in the MS patients versus the healthy controls, the MS patients are using more cortex and more supplementary cortex, even though they have normal function in their dominant hand. Their brain is adapting, and this is representative of cortical remodeling. And there are other mechanisms that underlie the recovery of function in MS. So to summarize this first part of the talk, MS is a much more active disease by MRI than you would expect based on relapses. And again, 90 to 95% of new lesion formation is actually silent, but it is contributing to brain volume loss over time. The rate of new lesion formation and relapses are decreasing as a function of age, and in many patients will actually stop by the time they're in their mid-50s or 60s. But they continue to progress, and this is due to untreated MS, but also due to the effects of aging in a brain that does not have neurological reserve. So one other finding that I wanted to emphasize is that the loss of neurological reserve doesn't just affect the onset of progressive disease, it also explains the results of clinical trials. And that is that in relapsed remitting MS patients, when we treat them with highly effective therapies, on average, the patient population is actually improving in neurological function. Whereas in progressive patients, the best we can do is slow the disease down. This was demonstrated by this paper from Alistair Cole's group looking at an alemtuzumab trial where they had secondary progressive patients and relapsed remitting patients that were relatively similar in age group. And what you can see in the 1 year run-in follow-up, where they were just observing the patients, both groups worsened on their disability scores. They were then treated here at the beginning and followed up every 6 months thereafter. What you can see is after 6 months, patients on alemtuzumab with relapsed remitting disease actually improved their disability by more than 2 points. Whereas the patients with secondary progressive slowed down the rate at which they were getting worse, but they're still a little bit worse. Now, the relapsing group continued to improve slightly at every follow-up period, whereas the progressive patients continued to slowly decline. And I would argue that in this case, this is a highly effective therapy, and this may represent some ongoing MS disease activity, but also the effect of aging on a brain that has used up its neurological reserve. So again, I would argue the therapeutic goal for all of our disease-modifying therapies is to preserve brain volume in early disease. Then I'd like to switch and talk about the emerging role of B cells as a key player in the pathogenesis of MS and also a key therapeutic target. So a very important observation was made last year in 2015, and it really changes our way of thinking about the brain. You may have been trained as I was that the brain is an immunologically privileged site. It's different than other organs in that sense. It turns out that that's not the case. There are actually lymphatics in the brain, and these lymphatics do drain out along the jugular foramina and the other vascular foramina into deep cervical lymph nodes. And this is just showing experiments where they injected trypan blue into the subarachnoid space and found that the deep cervical lymph nodes, but not the superficial lymph nodes, were actually stained. And we now have good anatomic evidence that these lymph nodes, these deep cervical lymph nodes, are connected to the subarachnoid space by these lymphatics. Very importantly, as you know, it's been generally understood that the B lymphocytes that enter the brain are clonally related. They're members of a clonally expanded family. The UCSF group reported they were able to find members of this clonally expanded family in the blood. And also they suggested that by doing deep sequencing of the B cell receptors, that it appeared that the B cells were expanding in the periphery and then moving into the brain. This was confirmed by a study from Yale, just published this last year, this study, and where they were able to obtain donations of 5 patients' bodies for research purposes. And they sequenced the B cells in the brain, and then they compared those sequences to B cell sequences in the deep cervical lymph nodes and the thoracic lymph nodes. And what they demonstrated is that the deep cervical lymph nodes were producing the B cell clones that were going to end up in the brain and become part of this clonally expanded family. So we do not know what it is in the CSF or that's moving in these lymphatics to the deep cervical lymph nodes that's causing this expansion of these autoaggressive B cells, but we now have the anatomic sites pretty well identified. So B cells have multiple functions. They can certainly produce antibody. They can provide antigen presentation and co-stimulation of T cells to allow them to mature into memory T cells and ultimately become effector cells. They produce cytokines that affect T cells, but also affect many other cell types in the vicinity. In the brain of MS patients over time, we do see ectopic B cell-like follicles, particularly in the meninges. And it's not clear what role these are playing in the pathogenesis of MS at this time. So to summarize the immunology model that we now think is going on in MS is that we have both T cells and B cells crossing the blood-brain barrier, entering the perivascular spaces. And there, the B cell becomes activated and becomes a very effective antigen-presenting cell and can promote T cells down a memory pathway. It also, though, releases cytokines, interleukin-1 beta, interferon gamma, and others that cause astrocytes to turn into reactive astrocytes. These reactive astrocytes, or type 2 astrocytes, also upregulate INOS, and they produce tumor necrosis factor alpha. And these two molecules actually can lead to mitochondrial death, and we think maybe the basis for some of the oligoendocyte death and neuronal death that we see in MS. So this two-step process where we have both professional immune cells interacting with astrocytes in the brain is actually now a therapeutic target in MS, and we have treatments that affect both aspects of this particular interaction. I'm going to focus on the therapies that affect B cells for the next few minutes, though. So it actually, as you know, we have about 14 different therapies approved in the United States and variable numbers approved elsewhere in the world for treatment of MS in terms of decreasing inflammation and decreasing relapse rates. Now, these drugs have many mechanisms of action. I'm just pointing out here that all of them also have effects on B cells, which tends to be overlooked. The field tends to focus on their effects on T cells, but in fact, they do affect B cells. So alemtuzumab actually does delete B lymphocytes, and when they repopulate, they come back as naive cells. Dimethylfumarate interferes with IL-12 and IL-23 production, which is important for B cell maturation. Fingolimod induces a regulatory population of B cells that appears to be a part of their effector mechanism. We've demonstrated repeatedly that Copaxone works by inducing a regulatory population of B cells that then migrate into the brain. And all the other therapies also have effects on this. In particular, natalizumab down here actually blocks B cell migration more effectively than it does T cell migration into the brain. And of course, now we have the more selective therapies, rituximab and ocrelizumab, which bind to CD20, which I'll come to in a second, and selectively deplete B lymphocytes. So B lymphocytes, in terms of their maturation, come from the bone marrow, and they have variable markers on them depending on what stage of their development. The most important point for us, though, is that CD20 is a cell surface marker that is expressed from pre-B cells up to memory B cells and a few plasmablasts. And this can be a therapeutic target that turns out to be very fortuitous for two reasons. One is it does not destroy stem cells, so the B cell depletion can be reversed over time. And secondly, it doesn't delete plasma cells, either short-lived or long-lived ones, so immunological memory for influenza and other environmental exposures remain. And there's been some remarkable developments with this therapy, which we would assume to be highly immunosuppressive, but turns out in the way that we use it in MS is actually not significantly immunosuppressant, and we do not see much in the way of immune dysfunction related to infections or cancer. So this is a cartoon of ocrelizumab, but rituximab works the same way. So these antibodies kill B cells in several different ways. They bind to CD20, which is only expressed on B lymphocytes with one small exception. There's a small population of T cells that also express a little bit of CD20. But the effect of ocrelizumab and rituximab therapy is thought to be primarily through its effect on B cells. So they can bind to the cell surface protein of CD20. They can fix complement, which can kill the cell. They also can activate NK cell function, which will kill the cell. And they can also activate the cell-mediated cytotoxicity as well. Also, it's been found recently, particularly with ocrelizumab, that the B cells that are coated with anti-CD20 are effectively removed in the liver by Kupffer cells through phagocytosis. And that actually might be one of the more important mechanisms for removal of B cells from circulation. Now, rituximab was studied in the late 1990s and early 2000 in MS, and this was the first randomized clinical trial. This is the Hermes trial. So this was involved around 100 patients that were randomized 2-to-1 to rituximab versus placebo. They were given 2 doses of rituximab at a dose of 1,000 milligrams each, given 2 weeks apart, and then they were followed for the next 2 years. And basically, just after a single cycle of rituximab, the rate of relapse rate was reduced by 50%, both at 6 months and at 1 year, and it continued to be significantly reduced even out to 2 years. Importantly, by MRI, which was the primary outcome for this particular study, the patients that were treated with rituximab had their MRI by the time they reached month 4 go to essentially zero new lesions being formed. And this was maintained out to about, on average, about 16 months after a single cycle, whereas the patients on placebo continue to have active MRIs. This was a remarkable reduction in MRI disease activity. It was actually the greatest that we had seen from any therapy study to that point. This rituximab was also studied in primary progressive disease. This was the Olympus study. And this was a little bit different. Here, patients got the 2 grams of rituximab given as 1 gram each over 2 weeks, 4 times during the study. So this was a 2-year study with 4 cycles of 2,000 milligrams of rituximab. Patients were followed for an additional 6 months after the end of the 2 years. And unfortunately, the primary outcome was non-significant. So in terms of an intent to treat analysis on sustained disability progression or time to confirm disability progression, there was no real difference between the groups. However, in this study, there was a pre-planned analysis to look at subgroups to try to understand more where the drug might work. And what that showed us was that patients who were younger and patients who had active MRIs in terms of gadolinium-enhancing disease at baseline actually did respond to therapy. And we used a median age of the study to subgroup these patients, so age 51, that was just the median age. And again, in the older patients that have no GAD lesions, there's no difference. Patients less than 51 that did have a GAD lesion, there's a trend towards the end that they were separating, but not a major difference. For patients who were less than age 51 and had no GAD lesions, had an effect trend. But if they had GAD lesions and rates under age 51, even though there's only 72 patients in this group, there was a strong effect with a high p-value. So the point of this is that what I was telling you earlier is that inflammatory disease activity is greatest in early MS. And MS patients that have primary progressive disease appear to have had the disease for years to decades before we actually diagnose them. And so unfortunately, we're catching them too late, and we're catching them at the point where they have relatively little inflammatory disease activity, and that's why we get relatively little effect on them. But if we can catch them earlier, we can actually change the outcome, and this is confirmed by another study that I'll tell you about. The adverse effects of rituximab were actually remarkably benign. Now, in the Olympus trial, remember they're getting 2 grams of rituximab every 6 months over 2 years, and we did see a rise in infections, particularly in pneumonia. So at that dose, we do see some evidence of immunosuppression and increased risk of infections. However, importantly, the immunoglobulin levels, by and large, remain normal, except in the IgM group. So we did see a drop in IgM levels, but we did not see a drop in IgG or IgA. And the formation of anti-drug antibodies was actually quite low. It's around 6 to 7%, which actually, in people who have never been exposed to rituximab, there's 3 to 6% of people that will still carry these anti-drug antibodies. Another study that we presented at the American Academy of Neurology and was confirmed by the Swedish group is that rituximab is highly effective at preventing the rebound in MS disease activity that occurs in many patients when they discontinue natalizumab suddenly. So this was, in our center, we were able to identify between 50 and 100 patients that had switched from natalizumab to either rituximab, dimethyl fumarate, or fingolimod. And what you can see is that in the rituximab group, there was essentially no MRI disease activity and 1 relapse out of 69 patients followed for the following year. Whereas the dimethyl fumarate patients, we had a little bit more relapses and significantly more MRI disease activity, which was also true in the fingolimod group. So these are not big differences, but again, it just points out that rituximab is a highly effective therapy. This is rituximab versus fingolimod. This was a recently published study, just came out a few weeks ago from the Swedish group. The Swedish consortium of MS centers is one of the largest users of rituximab in the world. They have over 2,000 patients on rituximab. And this is just an open-label observational study of patients that were treated either with fingolimod or rituximab and followed. And what you can see here is that if you look at the proportion of patients that were without relapse, this is the rituximab group. So 95% of them remain free of relapses, whereas about only 80% of the patients on fingolimod remain free of relapses. This was also demonstrated in terms of safety. So these are percent of patients without an adverse event due to the drug. And this is rituximab up here. So on about 10% of patients had some adverse effect related to the drug, whereas with fingolimod, it was more like 20% of the patients. And then this is looking at compliance. You can see the patient on rituximab are more likely to stay on that over the course of 500 days or a year and a half versus patients on fingolimod. And this is our experience too. We see about 20% of patients discontinuing fingolimod over the course of 2 years for usually tolerability and disease activity reasons. Now, more recently, there is a newer version of rituximab, ocrelizumab, that has been studied and actually has completed several phase 3 trials. To give you a little bit of history here, we started the work with rituximab supported by Genentech, and then they decided to stop development back in 2004 or so because they realized their patent was going to run out on rituximab in the United States and in Europe. And in fact, it did a year or two ago. And so they had a newer version, a more humanized anti-CD20 called ocrelizumab, which they took into clinical trials. And now, basically 10 years later, we've completed that development. And there are 3 major studies I'm going to mention to you. So the first is the phase 2 trial that was done in relapsed and remitting MS, published a number of years ago. They now have 8 years of follow-up for safety of this group, which is very important. And then there are 2 large phase 3 trials that were essentially identical in their design. They were 600 milligrams of ocrelizumab compared to Rebif, interferon beta-1a sub-Q 44 micrograms. There was also a study in primary progressive called the Oratorio study that also used 600 milligrams given as 300 milligrams given twice over 2 weeks, over 2 years in primary progressive patients. So just briefly, this is the data from the ocrelizumab phase 2, looking at the mean number of gadolinium-enhancing lesions. And again, like we showed you before with rituximab, after about the first 3 months, the MRIs become almost silent in this patient population, whereas in Rebif, in placebo, they continue to be quite active. This is the relapse rate reduction from the phase 2 trial. It's basically an 80% reduction compared to placebo and about a 60% reduction compared to interferon beta-1a. So now I'd like to just briefly go over the OPERA 1 and 2 results, primarily to reinforce what we saw with rituximab. So these studies were quite large. They included 800 patients each. It was, again, ocrelizumab at 600 milligrams every 6 months compared to interferon beta-1a given 3 times a week. So an important point about this is these patients were quite young. They were in early phase disease. And in fact, more than 70% of them in both groups had not been treated with any prior disease-modifying therapy. So these were relatively treatment-naive patients. So compared to Rebif, ocrelizumab reduced relapse rate a further 46 to 47% in both studies. And the actual annualized relapse rate is 0.155, which again is comparable to the best of any other studies that we have. In terms of sustained disability progression, it succeeded in both studies with a high p-value, about a 40% reduction in risk of sustained disability progression, defined as either 12 weeks or 24 weeks. This is looking at MRI disease activity as measured by gadolinium. It's basically a 95% plus decrease in gadolinium-enhancing disease activity compared to Rebif in this study. And if you look at T2 lesion volumes, the evidence is that most of the disease activity actually was occurring in the first 3 months. And then after that, the MRIs became essentially silent. So this is an important point I'd like to reemphasize. And that is that if you treat patients with anti-CD20s, any disease activity that they have at baseline is probably going to run its natural history, which is over 2 to 3 months. But what the drug does, it prevents the next wave of inflammatory activity very effectively, much like natalizumab. And then there was exploratory outcomes, and that included brain volume. So this is in the OPERA 1 study. This is a statistically significant decrease in brain volume by ocrelizumab versus Rebif. And that was true in the OPERA 2 study as well. And in terms of patients that had no evidence of disease activity, that was increased by 64% by ocrelizumab versus interferon beta-1a. And also just emphasize here that in our clinical experience of about 600 patients that we've treated with rituximab at our center, this patient population is actually, in relapsed remitting disease, tends to improve in function as a group, much like we saw with natalizumab, published multiple times over the last decade. And then finally is the oratorio study. This is the ocrelizumab versus placebo in primary progressive MS. Again, the patient is getting 600 milligrams of the drug every 6 months versus placebo. And the key outcome was that it did reduce the rate of sustained disability progression by 24%. It did reach statistical significance. And this is the first time we've had a positive result in a primary progressive study. And a key difference between this study and the natalizumab and fingolimod studies is that this patient population was significantly younger. The inclusion criteria limited the age to 55, and there was an active effort on the part of recruitment to recruit younger patients. So the median age in this study is 44 years, whereas in all the other studies is 47 to 49 years. And that 4 to 5 years of difference in age explains why they were successful in this study and the other studies were not. And again, it has to do with the decreasing rate of inflammation in older patients. And again, serious adverse events were actually less in the ocrelizumab group compared to the interferon beta 1A group in basically all categories, or certainly no worse. There's no trends for any strong signals there. And the safety data, like we had from the rituximab studies, is quite good. This area here, these are the infusion reactions that occur. So we do see them with ocrelizumab. About a third of patients will have infusion reactions, but they're generally mild to moderate, pretty easy to manage. We do see a slight rise in influenza and upper respiratory tract viral infections. And this has been consistent across most studies. We don't see a consistent trend in any other infections. It's really limited to influenza and viral URIs. And it's a small effect, about 3 to 4% increase over background. So in summary, we have these new drugs that target B cells pretty selectively, appear to be highly effective, also appear to have a very good safety profile. We do have 10 years of follow-up in both rituximab patients and ocrelizumab patients. Both the Swedish group and our group have reported our experience in this. And again, even out to 8 to 10 years, we do not see a rise in infections. It appears that the reason for this is that the doses that we currently use of rituximab is 500 milligrams every 6 months. We do 1,000 milligrams induction, but then we reduce the dose to 500 milligrams every 6 months. And that was just based on empiric evidence that it worked, and we weren't running into infectious complications. The Swedish group has done the same thing. And then ocrelizumab did a dose titration study and found that 600 milligrams was as effective as 1,000 milligrams. So we're using much lower doses than we're used in rheumatoid arthritis or lupus, and certainly lower than lymphoma. And we also use it as a monotherapy here, whereas in those diseases, it's used in combination with other immunosuppressants. So you can't transfer the safety experience from those diseases to MS. We think that the reason we're not seeing a drop in immunoglobulin levels in general, again, is that we're using a low dose that's not depleting B cells from tissues. In other words, we're not depleting lymph node-based B cells, splenic B cells, or the tissue-based B cells. We're deleting a circulating population of B cells. In MS, based on that biology that I just told you about, that there's a key cycle of B cells moving out of the cervical lymph nodes into the circulation and crossing the blood-brain barrier that drives the inflammation. We do not yet know why it's required to have B cells continually migrate across the blood-brain barrier in order to maintain disease activity. There appears to be something that happens to them inside the brain that eventually terminates their pro-inflammatory effects. We do not know what the biology of that is. But it does appear to be the case that both in natalizumab and in the case of rituximab, we have evidence that B cells are still in the brain, they're still producing all-clonal immunoglobulin, but the disease activity has decreased by 90% in terms of MRI disease activity. So it appears that this circulating population of B cells are key drivers of the disease, and we're just lucky that we ended up at doses that deplete them without depleting other B cells in the tissues, and thereby we maintain immune surveillance essentially in a normal state. Oh, I'm sorry. I meant to point out in this particular slide, though, that the most important outcomes that we think now are actually in clinical trials are actually decrease in sustained disability progression and effect on brain atrophy. And the interferons in GA tend to have a relatively small effect at this level. The oral drugs are sort of intermediate, and the monoclonal antibodies, including the anti-CD20s, natalizumab, and alemtuzumab, tend to have larger effects in this area. From a safety standpoint, it's all about patient selection. So for natalizumab, JCV antibody negative patients that are continually followed for JC status have a very low risk of a serious adverse event from natalizumab. And in the case of rituximab and ocrelizumab, again, we're not seeing much in the way of serious adverse events occurring in this patient population. So it is possible to use these monoclonal antibodies almost as safely as we can with the interferons and GA. And I would argue probably safer than the interferons if you include all adverse events as well as serious adverse events. So our assessment of risk-benefit, I think, is changing now as we have more experience with these drugs, longer follow-up, and larger patient populations that are treated. This happens to be our treatment strategy at the Rocky Mountain MS Center. We have 9 clinicians here. We have about 3,500 distinct MS patients we follow with over 10,000 patient visits a year. And as a group, we've decided to try to develop algorithms for different patient populations in terms of what the data tells us. And based on a consensus from the group, which we actually have no exceptions, for patients that are uncomplicated and don't have a lot of other comorbidities, the anti-CD20s would be our top choice, even in patients who are JC negative. And the reason for that is that in natalizumab, if even patients JC negative, they have a 3 to 7% chance of converting to JC positivity each year, so they have to monitor that. And we have the rebound effect when we take patients off the drug, chance that they'll actually have a rebound in MS disease activity. We don't see either one of those issues so far with monotherapy with anti-CD20s. There's been no cases of PML, and there's no rebound effect. So in terms of quality of life, the other advantage of these are that these are only twice-a-year IV infusions, again every 6 months. It allows us to treat patients in almost a destination clinic model. In other words, our patients who are younger, healthier, who don't have a lot of symptoms of MS, and treat them as newly diagnosed, they only have to deal with it twice a year. They come to the clinic, they see us, we do the safety blood test, they get the infusion, and they're good for 6 months. And also, ocrelizumab, we expect, will be the only drug approved for all forms of MS. And by extension, I think there's no reason to think that rituximab can't be a player in that particular space as well, based on the data that we have. So I'd like to thank you for the time and the opportunity to talk with you about this. It's a remarkable time in MS that we have so many therapies that we can use. It makes treating MS more complicated in some sense, but also we are far more effective than we ever were before and can make a huge difference in what happens to our patients over their lifetime. Thank you very much. Okay. So I have some questions that are coming up. I would argue that rituximab, that we have class 1 evidence that rituximab in early progressive MS, young patients, less than the age of 45 to 50, that it is an effective therapy and can change their outcomes. And it's consistent with the ocrelizumab study in the oratorio study. So we do use it in primary progressive MS. We actually use it in all of our patients, at all forms of disease, including CIS. And I can tell you that our experience is what I showed you before. If we use it in newly diagnosed relapsed remitting patients, by year 2, most of them come back and will say they don't feel like they have MS anymore. So these patients newly diagnosed that didn't have a lot of residual disability when we first diagnosed them and treated them early. In patients that have relapsing forms of MS that have had the disease for a while and do have some symptoms, they will come back in 2 years and generally tell us that they're better, but they still have problems, particularly when they're fatigued or hot. The patients with progressive disease, either primary or secondary progressive, after 2 years of treatment, they will say, I'm not changing as fast as I was, but I'm still slowly getting a bit worse every year. And again, we're encouraging them to exercise and adopt healthy lifestyles in order to supplement this. And particularly in the relapsed remitting patients, if we can get them to exercise, they really can have rather remarkable recovery of function. And this is consistent with our experience with natalizumab and fingolimod as well, where we have similar large exposure to them. Second one is that what is the chance of PML with rituximab in relapsed remitting MS? Well, there has been cases of PML with rituximab as used in lymphoma, rheumatoid arthritis, and lupus. However, in all those cases, there were other risks for PML, namely immunosuppressants, or they had lupus, which is a known risk factor for PML. But if you assume that all those cases of PML were actually due to the rituximab, then the risk is about 1 in 30,000. As you know, the risk in JC positive patients on natalizumab for PML is about 1 in 200. So it's a marked difference. So far, there's been no reported cases of PML in patients treated with rituximab as a monotherapy. there's been no cases reported of ocrelizumab either. Another question is, how do I rate oral therapies in MS treatment? Certainly for the JC positive patients, we tend to use both fingolimod and dimethyl fumarate, and we have relatively large experience. Our experience is that the tolerability of dimethyl fumarate is significantly lower than it is with fingolimod. We have about 30% of patients which will discontinue dimethyl fumarate over 2 years, and that experience was similar at Cleveland Clinic. They had the same experience. With fingolimod, it's about 20%. With rituximab, it's about 5% that will discontinue the drug over 2 years. Question about the prevalence of MS in children versus adults. About 8% of MS patients will be diagnosed prior to the age of 18. And median age in children is usually around age 12 onset, but they can be as young. I've seen a 2-year-old with MS. This is a very important group because it's often felt that they have milder form of disease because it takes them longer to reach an ESS of 6. But I would emphasize that these are children. They have very plastic brains that have a lot of reserve capacity. And even if they take longer to become disabled, they're becoming disabled in their mid-20s or early 30s with serious disability. So we obviously, this is a relatively rare disease. We do have some published experience, particularly with natalizumab in this population. And these patients respond to the immunological therapies the same as adults do. We have pretty much the same risk profile so far. So we have about 120 children with MS in our clinic here. And then the question is, if the OX4 antibody is negative for suspected NMO, and still the diagnosis can't be established, what should the line of treatment in such cases be? I would argue that if you can't make a definite diagnosis of NMO versus MS, then the only therapy that really is highly effective in both is actually the anti-CD20s, in this case rituximab. There is a anti-CD19 trial going on in NMO, and there's also an anti-CD20 trial going on in NMO. But we know from our experience that rituximab will decrease disease activity in NMO by more than 80%. And as we just talked about, it decreases MS disease activity too. Unfortunately, the experience with natalizumab and NMO is on the contrary. It appears that many of our other therapies actually worsen NMO, including the interferons and natalizumab, which both been reported on. So at this time, I would say if you're not sure whether it's NMO versus MS, then an anti-CD20, particularly rituximab, would be a good choice since it'll control both of them at a very high level with a good safety profile. Question, would I recommend use of rituximab in RMS? Yes, I do. In our state, in Colorado, Medicare, Medicaid, and the VA system all cover rituximab as a first-line drug for us. We're the only state in the union that has that, but ocrelizumab should be approved here first quarter of next year, and it'll be approved as first-line use as well as approved for all forms of MS. So we find it a highly effective therapy. Patients like it. In fact, in terms of preferences, about 70–80% of patients who have had rituximab or the oral agents will prefer rituximab over the oral agents because of the fact they don't have to deal with it twice a year, and it's more tolerable, has fewer side effects, and less safety monitoring. The question is whether rituximab is more effective in the progressive form of MS versus the relapsing form. I think it's the opposite. It's very effective in the relapsing form, and it can help slow down progressive disease, but we've not been able to stop it. And I don't know whether that's due to the fact that there's a different inflammatory process that's continuing to drive it, that we're not able to affect these drugs since they don't really cross the blood-brain barrier very much, or whether it's really just unmasking aging and deconditioning as a result of disability from MS. So I think it's probably a bit of both, but I would say with all the highly effective therapies, which I include fingolimod and natalizumab in, that the earlier you can use them in the disease course, the larger the treatment effect you're going to see in the patients. And as I said, we don't currently see patients that have relapse-remitting disease that we treat with these drugs moving on into the progressive form of the disease. So it does really seem to prevent that, although I would argue that I would also agree that there's not a lot of long-term data yet. And the last one is, what is the line of management in relapsing MS in countries with less healthcare resources? That's a tough question. I really don't know. I don't know the economics of the different drugs. You know, again, I think that the anti-CD20s in particular are attractive in that it's a class of drugs we've had for 20 years. I think they're relatively widely available in the world. And the management of patients is relatively simple. And we just do a CBC and a CMP every 6 months along with the anti-CD20 panel B-cell count. Screening tests are simple. It's hepatitis B, C screening to make sure they don't carry either one of those, and also a screening for tuberculosis. So if patients are not on other immunosuppressive drugs, don't have a primary immunodeficiency syndrome, don't have hepatitis B or C, and aren't infected with TB, then they're a candidate for rituximab, and it's a fairly easy therapy to manage and monitor. Outside of that, I would say probably fingolimod would be my second choice, but again, I don't know what the cost of these drugs are in other countries. And fingolimod in otherwise healthy people is also relatively easy to monitor. The problem is there's a larger population of patients that have cardiac, pulmonary, or other problems you can't use fingolimod. And the last one question here is dosing schedule for rituximab. Our use of rituximab in all forms of MS is the same. We no longer do the 2-gram induction dose that was done in the original studies. It's not necessary. 1,000 milligram induction dose fully depletes 95% of patients. And then we have found that 500 milligrams given every 6 months maintains patients in a depleted state with only about a 5% escape in terms of B cells recovering. And generally, if we just continue the rituximab for another couple cycles, they are fully depleted again. So it may be the emergence of anti-drug antibody that transiently decreases effectiveness or something, but it's a very minor problem. And we have relatively little disease activity and relatively little in the way of adverse events that we're dealing with the patient. So rituximab and ocrelizumab appear to be similar in their effectiveness in deleting B cells from circulation. And so in both cases, we're in the 500 or 600 milligram dose every 6 months. And that's much lower than used in the other diseases, and I think is why we have such a good safety profile in MS. Okay. Well, again, thank you all for the time that you took. Hopefully it was useful. Our treatment opportunities are getting...
Dr. Vollmer, it was really a insightful and thought-provoking session, I should say. And believe me, you have really made a statistically significant difference in the knowledge level of each and every attendee here. Then I really feel highly privileged as I have been asked to propose a vote of thanks for this session. At the first place, at outset, I would like to thank Dr. Vollmer on behalf of Intas Pharmaceuticals and the whole fraternity, neurofraternity gathered here, and on my own behalf also. I would like to extend my thanks to you for gracing this occasion with the wonderful deliberation on multiple sclerosis. And each and every information shared by you is going to help each and every clinician who has been here, who was a part of this session, to treat the MS patient in a better way. So thanks a lot, Dr. Vollmer, once again.
Thank you.
I would also like to thank the whole fraternity gathered here for taking their important time from the busy schedule and coming here and making this session more interactive and meaningful. So many thanks to everybody who has been a part of this webinar from the Intas Pharmaceuticals, with anticipation that you all will cooperate in the same way for such kind of future events. And at last but not the least, we would like to thank our technical and broadcasting partner, Team DocMode, who had conceptualized this convenient platform of webinar and have run this platform in a very smooth and effective way. Once again, thank you everybody. Keep on enjoying the science, and good night.
Good night.
Good night.
Hopefully our patients will have access to these medications that can fundamentally change their outcomes. Thank you very much.